I myself is the last speaker of this session, so I will go on with my slides regarding the economic impact of spectral CT in oncology. So this is part of the study that we did that Aska presented in the beginning of this session of the 503 patients, where we also looked at the economic impact of what the diagnosis and what the characterization means for these patients. So if we look at the study design, the results, the discussion, and then conclusion in the end. The study design itself is from the original 503 patients. We had initially a little bit more, 536 patients. And of these were some excluded, and we had 400 patients in the end that all had written consent and all had an description of what added examinations they would need in order for follow-up of the lesions that we found in the original scans. So this was a subpopulation of the clinical study, and all the suggested follow-up procedures were recorded as mentioned. This was based on the best clinical practice. So for pulmonary nodules, for instance, we used the Fleissner Society criteria for follow-up of these nodules. The same for thyroid lesions, for instance, how we would follow that up in regarding to the American Society of Radiology's guidelines or the white paper from them, etc. So these were for all the lesions that we could mention. The primary outcome was the reduction of follow-up procedures and the estimated cost saving based from a Danish payer society and the US system in order to account for the differences between the payer systems that are in different healthcare systems. So looking at the results from here, the overall results is that we get an estimated cost saving per patient or per follow-up for follow-up procedures of 130 euros. That's quite significant, right? So looking at that, we saw a decrease of examinations from 573 to 370 on spectral CT. So we almost decreased the amount of added examinations by 200 in only 500 patients. If we dive into that and look at the individual organ systems, because this is driven by a certain findings, looking at liver lesions, we see here that there is a real reduction in follow-up procedures of 78. So this is one of the primary drivers of those 200 less examinations that we find in the overall results. So this also, if you see here, the reduction in cost savings is around 50% just looking at liver lesions. And if we look at the cases from this is why the reason that we get this reduction is, if you look at this case here, this is a patient that actually have a pancreatic cancer. You can see the dilation of the internal gallways. So the lesion here in the anterior part of the liver, of the right liver lobe, is that a metastasis or is that a benign cyst? So how many believe that this is a metastasis? Nobody? All are completely sure that this is a cyst? I hope that I'll be working with you every day because you're completely right. Because if you look at the set effective here, it has water values, 7.4. And if you look at the iodine overlays, no iodine content within this lesion at all. So what about this one? This is a patient with a colorectal cancer. Metastasis or cyst? Same question. If you look at the conventional Hounsfield units, there's no difference. It's almost the same. I would still be in doubt here, but when we have the spectral information, we're not really in doubt anymore if you look at the spectral overlays. This is the iodine overlay images. And the enhancement of this lesion is 2.02 milligrams per milliliter. And it's a metastasis from the colorectal cancer. And it was proven by biopsy. Just to show the measurements here that I'm not lying to you, the average of 2.02 milligrams per milliliter. So in one case, we can say this is just a benign cyst. We don't have to do any follow-up. We don't have to do the ultrasound or the biopsy. We can just discard it and say this is nothing. And in this case, we can go on and say we want to do a biopsy directly because that's what's needed. So the next topic is the kidney, because this is also one of the cases that Aska showed you earlier today. And you can see here that one of the reasons that this is driven is that we get a reduction of almost 58 procedures in this case, and most of them are ultrasound based on high-density lesions within the renals, within the kidneys. And mainly, we drop it from around 64 with contrast-enhanced CT to around 3 with spectral CT of suggested follow-up procedures for ultrasound. So it's quite a lot, really, that we get this reduction. And you can also see here that the cost savings is a little bit different between the Danish system and the US system, because the ultrasound has a relatively high cost in the Danish system. So this lesion here, and you've probably all seen these cases, this has a high Hounsfield value on the conventional CT, around 60. So hyperdense cyst or renal cell carcinoma? That's the question always, right? And if we don't have the spectral information available to us, either we have to do a non-contrast CT or we have to do an ultrasound in order to actually characterize this lesion. So in this case, we actually had the spectral information from the icon scanner, and you can see here there is no iodine enhancement, 0.2 is no enhancement, and it has water values on the set effective on 7.4. So we're not really in doubt here. We can say this is just a cyst, we don't have to do the ultrasound, we can just go on to the next patient. Almost similar here, right? Right kidney, lesion in the anterior part of the parenchyma. So is this a cyst or is it this malignant lesion? On the conventional images, the Hounsfield values are almost the same, around 60. The thing is, we can probably see here this is a little bit more heterogeneous compared to the other one that we saw before, so we would probably pick this up and say this could be something else than a cystic lesion, right? But we would still have to do something extra for it. But here we can actually see that there is an iodine enhancement within the lesion, clear iodine density, and you can also see here that the change from the conventional to the mono is increasing a little bit. So this could be diagnosed as probably a malignant lesion and go directly for biopsy, or follow-up if that was the case in those cases. So the last one I want to show you is the adrenal glands. We all know that the spectral CT can help us in actually differentiating between benign adenomas and something else, something that needs to be followed up. So when we look at it, this was driven by fewer dedicated adrenal CT scans, the decrease in overall amounts of follow-up procedures, which was reduced by 25 in the overall population. So we use dedicated adrenal CT in Denmark, so they get a non-contrast CT, and if we're still in doubt and the Hounsfield values is more than 10, we go for a washout CT afterwards. It could also be MRI in phase, out of phase. We can use both modalities. So we get an overall reduction in cost of around 62% in both the US and the Danish payer system. And just to show you here, it's the case here where you can see the lesion in the right adrenal gland, and you can see here that it's enhancing and it's a contrast enhanced CT, and on the VNC we get a very low Hounsfield values, and this is minus 0.6, and we can say this is just an adenoma going on. And there are some debate on what is the cutoff values for these, and I know that Dr. Niels Hokamp from Cologne has actually shown this in a publication, or I'm not sure if it's published yet, where you can see if you can even go higher than we normally go with the Hounsfield values of 10. You can probably go to even 20 and still be on the safe side when differentiating between metastasis or malignant lesion and the adenomas themselves. So we on our institution still use 10 as our cutoff because we're not really there yet to go higher. We probably could. So for the discussion, there's been some other publications looking into this as well. There was a retrospective study of 2,400 patients that found a reduction in the recommendation for additional imaging going from almost 12% to almost 9%, so a 3 percentage point reduction in the amount of follow-up examinations in all these patients here. So quite light, that's around 75 cases that they had a reduction in. And there was also a retrospective study of 69 patients with abdominal pain, where you can see that spectral CT characterized 27 incidental findings and saved 15 follow-up examinations, and you had a cost saving of $85 per patient. So the question is always, what about the time when we're looking at spectral imaging? Because does it take longer time to look at compared to a conventional CT? Even though we have a cost saving, if we use more time as radiologists, then it's the question, is it really something that we should do? And in the study that we did, we found that we had an average increase of 82 seconds per case when looking at spectral information. And I would say this is probably a little too long today, because the way that I read today is much different from when we did the study. So when we did the study, we still used the conventional images because we were not really sure what we were looking at, etc. But today, I only use my monoenergetic images as my primary reading series, so I don't use the conventional anymore. And if you do that, that time will decrease. So it doesn't take me longer today to do a spectral CT compared to a normal CT. I'm fairly certain. So in conclusion, contrast-enhanced spectral CT reduces the need for follow-up procedures and reduces overall cost. We had a reduction of more than 200 follow-up procedures in 400 patients. And the cost reduction per patient was 130 euros going down the line compared to just using the spectral information. So thank you for your attention.